I didn't expect to start at this place, but you said to tell people where I'm from, and I suspect, before I say anything else, everybody can guess generally where I'm from, and it's not Boston or New York City. My name is Dane Wallace, and I feel a little silly introducing myself because this whole half of the room is sick of hearing who Dane Wallace is because they're paramedic students at Matsu College. And that's my job. I'm the paramedic assistant professor of paramedical technology and EMS program director for the South Central Paramedic Program of the University of Alaska Anchorage at Matsu College.
Wow.
That's my actual official title, and it sounds really good. It looks really good on paper, but 10 minutes with me and you realize really quick that you know what they call a paramedic who made 82% all the way through his training? Any idea? They call him Professor Wallace. So spending about 5 minutes with me, you're going to figure out very quickly that hopefully I'm just an ordinary guy. I'm a paramedic who also happens to be a college instructor. So I would like to keep things pretty low-key, pretty real, pretty simple, and maybe even provocative as we go through this information. I'm glad everybody's here. I'm sort of talking to a vacuum, so if I'm not making, I usually make really good eye contact with everybody. I'm imagining this cyber cloud filled with people listening to my voice right now, which it's not pleasant. So let's talk about trauma. I was really happy. How many people in the room got a chance to listen to Dr. Quimby talking about sepsis last month? Okay, it was really good. And if people in cyberland are raising their hand or nodding their head up and down in a vertical manner, you're right. It was really good. Dr. Thomas Quimby is an emergency room doctor up at in our neck of the woods up in Palmer, Matsu, Wasilla, the Valley, however you refer to it, and gave an excellent lecture on sepsis and sort of like the pathophysiology of sepsis as an emerging problem, a growing problem that is particularly of interest to the hospitals because the hospitals are being assessed now by CMS, which is the Center for Medicare and Medicaid Services, federal government. And how the patients, how well the patients do as a result of the care that they receive in the hospital by CMS now. And if CMS does it, if Medicare and Medicaid, the largest payer of healthcare services in the world, says this is how it's going to be, that's how it's going to be. And it's interesting to hear an emergency room doctor talking about a metric, a way that the hospital is measured in terms of patient outcomes, and then kind of turn that around to a clinical understanding of how to take care of a person in the hospital, and then what are those big sort of problems. And so sepsis is an emerging problem in the hospital, and you guys are thinking, I thought this was a conversation about trauma. It's not. It's a conversation about patient outcomes. And Dr. Quimby brought that in a very real way last month when he was talking about how oriented hospitals are now on patient outcomes. And you think, well, you know, if you're a healthcare professional, if you view yourself as a pre-hospital emergency medical care professional, and whether that's in the military combat arena or whether that's in civilian EMS, you're probably just inside went, well, duh. Why would I not care about patient outcomes? Why would that not be the single motivating, driving factor in the fiber of my being for why I'm sitting in this class and choose this career? Why would it not be patient outcomes? Let that marinate. But I'm here to honestly tell you, EMS as a culture has been so inward-looking about doing stuff for so long that, number one, on an individual patient-by-patient basis, we do not know our patient outcomes. We don't even know what the disposition, and I'm not talking about the discharge summary, we don't even know what the disposition diagnosis is, the ER doctor's working diagnosis when he moved the patient from the ER back home or from the ER to critical care or to the burn center or to the peds unit. And that's not the patient outcome. That's just a disposition summary that he stabilized them in the ER and moved them to the next place. So when I start hearing about Southern Region, bringing Dr. Quimby here to talk about sepsis and why sepsis is important and how managing sepsis is a metric for patient outcomes, I get very in tune with that thought process, because we got to do better at appreciating what we're doing. I'm doing air quotes, so cyberland people, imagine a really ugly, bald, country guy doing air quotes, and that's what this group is getting in here right now. What we're doing, you know what I'm saying? The stuff we do. See, in this room, let's just go around and talk about stuff that we do, because we're EMTs and EMT2s and EMT3s, and they do a lot, and paramedics. What do we do to people? We drag them around and stick stuff in them.
Backwards.
Oh my God. Somebody just said that we put them on backboards, which made me a little nauseous. But anyway, we do that. We put them, I have a whole preaching sermon on backboards. But anyway, we're not going there tonight. We stick stuff in, and we like to start IVs, and we like to give them medicine, and we like to do fluids, and we like to, I guess, splint. We like to do stuff to them. And that is just not good enough. Doing that stuff, which may seem like a good thing to do, if not done for the right reason and the right time, is just as bad as doing either A, not doing anything for them, or B, doing stuff that you know is bad for them. I like putting them on the back. Anyway, I'll go on. So what's the transition from my big praise session on Dr. Quimby's sepsis speech to trauma? We were birthed out of the need to get injured people from car accidents off the highway in the late 60s, early 70s. That's why we're under, currently right now, our profession, EMS, is under the federal government oversight of the National Highway Traffic Safety Administration, NHTSA, which is where all professional healthcare providers are credentialed and trained, right? NHTSA, highway people. Now, other professional healthcare providers are in the Department of Sanitation. Department of Health and Human Services. But we're not. We're not under the auspices of that department. Did you recognize, did you know that in your EMT class? The book was sanctioned by NHTSA, and there's a little DOT symbol in the corner of the first page and all that fun stuff. As healthcare professionals, we're under NHTSA, and everybody else is under Department of Health and Human Services. And we're there because of a need in the late 60s as two things were happening. The highway system in America was developing, interstate systems, and federal money was going towards infrastructure improvements and those kinds of things. And the automobile industry was booming. The middle class was growing thanks to a long period of prosperity after World War II. And so what do we have? Really good roads and really bad, really looking backwards, bad cars. You know what I'm saying? You can get up, it's the same highway we have, I guess maybe not here in Alaska, it's probably not the same highway, because these highways are probably what? Some of them are maybe 70 years old. But they're not much older than that, 50 years old. But the interstates, the major interstates across the lower 48, they're the same highways that were put there back in those days. And you could go really fast then, too. But then you were going fast in like a 1957 Buick. I mean, this thing was like, forged from molten iron from the core of the earth. And you could just get in there and rattle all around and bang all around and stuff. And so it turns out that big giant Buicks clogging up the interstate is not in the best interest of the Department of Transportation. And it also turns out that having hearse drivers come and try to clean that mess up and towing truck companies was not in the best interest of the general public. So they scratched their head and said, hey, we probably should create an EMS system. An EMS system. Funny, you say that now, it makes sense. Back then it was an emerging idea. It was trauma 1.0. Injured people on the highways of the United States stuck out there on these long, vast stretches of road in car accidents, badly injured, because the cars weren't as safe as they are now, and they had to go somewhere. So, EMS. It's fantastic. So that's the history of our birth and origin. That's the genesis of why we exist, is that moment in time, and they were the agency responsible for it, and so they gave birth to us, and we still live there. I'm not sure it makes any sense anymore, because I don't think in those days they thought that you would be going into the residence of a person, for example, having an AMI and starting to give aspirin and nitro and do a 12 lead, and in some rural systems giving thrombolytics, starting to do resuscitation, right, reperfusion stuff right in the middle of their living room, or in the ambulance, or in the outpost clinic, or whatever that was. So we've changed a lot. Anybody in this room care to take a wild stab at what Trauma 2.0 was? Maybe military science. That's what we're doing right now. For the most part, culturally in EMS, Trauma 2.0 is what we do right now. We go there, we load and go, or we don't, and then we start 2 large bore IVs, and we put them on a backboard, and we give them wide open fluids till we get to the closest hospital. I mean, it sounds okay. It sounds good, doesn't it? I mean, that sounds like what we learned in school, right or wrong?
Right.
I'm not trying to embellish it. I'm really trying to make it unsexy. This is like those advertisements where they give you the before picture, like, some weight loss advertisement, where they give you the before picture, and the person in the picture just has their shoulders slumped down, and they're just frowning terribly, and their hair is messed up, and they didn't put any makeup on them, and they're like, this is the before picture. And then the after picture, it's the same exact person who weighs the same exact amount they do in the first picture, but their shoulders are up, and they're smiling, and their hair is up. I'm trying to paint this terrible picture of Trauma 1.0 and Trauma 2.0. Have you ever felt like trauma is the same thing over and over again? It's okay to be honest. Kind of the same deal, Some people got hurt. We went there. We did some scoopy action movement thingy with a backboard probably, and then we stuck them in our bus and went lights and siren to a hospital. But in between there, it's kind of like, we put some bandages on, we did some splinting, maybe we started an IV or two, ran some fluids, and we got in there, and it's kind of all the same. There's not a lot to learn in trauma. Have you felt that way before? No, you guys are just amazing too. I felt that way. Mid-career, I was like, we're going to do the same thing. Massive car accident. Okay, we're going to do the same thing we did for the last massive car accident. We're going to go pick them all up, get blood on us, and the floor of our ambulance. And then we're going to take them to the hospital. It's probably not like that, really. If you think more into it and more about it and get a little bit better look at it, it's probably not like that at all. I think I'm looking at a bunch of people who think I'm crazy right now. Is it the accent or the idea?
It's just you.
That's you. Spoken like a true paramedic student. So Trauma 3.0 is the stuff that we should know about trauma that we may not have thought about or did before, and the manner in which we need to manage our trauma patients going forward based on 2 things. What is in the best interest of the patient to improve their outcomes? I brought that full circle. I landed that plane rather nicely, don't you think? And what is the emerging evidence or the science that supports what we should be doing for our patients, not what we think seems like a good thing or what we think seems like the right thing to do. Because, to be candid with you, when I was a brand new paramedic, somebody told me I should start 2 large bore IVs on my trauma patients and run fluids wide open if they didn't have a blood pressure. And when you say that out loud, that makes sense. No blood pressure? Give them a blood pressure. People die if they don't have a blood pressure. They should have a blood pressure. And by God, I'm going to give them one. I could probably have done it better with a bicycle air pump, but whatever. They need a blood pressure, and we need to give them a blood pressure. I'm going to be honest with you. I keep going back to this backboard thing. It sounded perfectly reasonable back in 1987 when I first got first responder lifeguard training that we would take a long, rigid piece of plastic and ace wrap a person to it, like a big splint, They broke their femur, we splinted. They break their body, we splinted. It was reasonable to me. It was reasonable. There's new evidence now. It's probably not reasonable. So what I want to try to do tonight is take something that maybe you may have rehashed once or twice, or you might have even rehashed it 3 times about how to care for trauma patients. That can be. It's exciting. It's our bread and butter. It's what gave us birth, and it's cool, and that's what the public thinks we're doing. Have you seen those memes on Facebook? What my mom thinks I do at work, what the public thinks I do at work. what I actually do at work. You know what I'm saying? The public thinks that we are trauma junkies and that we dig that gory stuff. Because do they come and ask you, what's the worst thing you ever seen? What's the worst thing you ever seen? The worst thing I've ever seen is the toilet when I take over my shift. And my first duty as this bachelor degree paramedic is to clean that toilet. You know what I'm saying? It is not a sexy job, but it's got to get done. Trauma's not a sexy job. It's got to get done. I think we can do it smarter. I think we can improve the way we think about it, improve the way we approach it, and improve the things that we do, the stuff we're doing, all in an effort to do one thing. And listen to what I'm getting ready to tell you, because this is my heart. I'm going to cry if I keep talking. It's patient outcomes. When you go to any call, you're not just looking at a patient. It's the patient, their life, the future that they would have had as of that colon and semicolon in their life, or comma, whatever you want to call it, and their family, and all they're either going to get to do because of you, or all they're not going to get to do because of you. And I'm just not willing to, I'm kind of an old, burned out dinosaur guy who's been around this block a couple of times. I'm still just not willing to take good enough as good enough. We've got to constantly be pushing, got to constantly be thinking, got to constantly be reviewing and researching and understanding and trying to figure out if we're doing the right things so that patient outcomes improve. Past us, through the ER, past the ER to critical care, past critical care to rehab, and then all the way to home to make what?
Pancakes.
Pancakes. All the people in my class know that pancakes is a euphemism for living your life. Getting up on Sunday morning, going to church with your family, having that big breakfast. That's always fun, you know, having a big breakfast and stuff, and having a good life, a quality of life. Pancakes. Not the last time I'm going to bring them up tonight. All right, that was slide one. How am I doing? Do I have control now?
You should.
Am I pressing the wrong button?
Okay.
Did I do that or did you do that?
I don't know.
Okay, don't hold your hands up. Hands still. Let me see your hands. You did. I have no control. This is just like paramedic school. I have no control. Okay. Before we go any further, and on the matter of quality of life in the United States of America, a lot of the science and a lot of what we know today is because brave men and women in our armed services paid a huge sacrifice with their life. Some of them with limbs. They'll never do what they did before because they're bilateral amputees due to IEDs in some sandy place that you're never going to hear about or think about or go to. Some of them died because they got holes put right through their body because bad people or people who didn't understand killed them. And so when we talk about trauma in the United States and where we're going in the next year, 18 months, 3 years, the trauma, do not forget that those men and women laid their life down, and a very smart military didn't let that slide by without purpose or meaning. And so some of the evidence that we're going to talk about tonight, some of the information we're going to talk about tonight, behind every data point tonight, some individual was injured and either disabled or killed because of it. Don't forget that. It's important. And it's the other part of why I think it's important to have these kinds of conversations, because if those guys just die and I get my freedom, I forget about that sometimes, you know? But in my profession, I get to see sick people and hurt people. I still work on an ambulance in the valley. I go staff an ambulance out in the valley. I'm still a paramedic. I told you I'm a paramedic. I just happen to teach too. When I go and take care of a person, it's a reflection of how I value that soldier's life. I take what they gave and use it to help somebody else. So don't forget that as we're talking. So if you are an armed service, anybody in this room, prior military, current military, reserves, Master, thank you very much. I know that you are. Thank you much. If you're in cyberland and you're raising your hand right now, I appreciate your what you've done for us. It's now just a visual indicator of what I would like to do. I'm pressing the button. All right, so you may have seen this. If you've taken PHTLS before, have you taken PHTLS? Pre-hospital trauma life support? If you have, you probably saw this slide in the front cover of your book. If you haven't, you should take it. It's a good class, and it'll re-emphasize, I sometimes forget the word I want to say, re-emphasize some of the things that I'm saying here, and already some of that information is dated, but this really gives purpose to our work. The fate of the wounded rests in the hands of the one that applies the first dressing. We are, in essence, in large part, the ones that apply the first dressing. You know what I'm saying? And the fate of the wounded is the outcome of that soldier, in this quote. In our case, it's the outcome of our patient. I'm just trying to re-emphasize what I said before. There's a reason why we should look carefully at what we do to improve the outcome of our patients. Look at the date on that guy. Nicholas Sen was a medical doctor from Switzerland who immigrated to the United States and did lots of stuff. Crazy big titles in his name. But at one point he was the chief surgeon in the 6th Army Corps, and he said this in like 1897. So 2 years later I was born, and I was just amazed by how powerful these ideas are. But that's a pretty powerful idea, and yeah. I think we need something else. I'll stretch my right. For Cyberland, if you hear giggling and sort of commentary back and forth between me and is it John? It's because my clicker's not working, and yet I insist on clicking it, and that's John's visual indicator that I'm trying to go forward. What I want to talk about tonight, what we're going to learn tonight, is what I want you to leave here with a better understanding, and not just be able to discuss the stuff we're talking about, but actually talk about it. If you want something to happen differently, or you want to change how culture works, or you want to change how something's working, it starts with discussion. It starts with intelligent people intelligently discussing that issue. And that dialogue leads to all kinds of stuff. So I don't want you to just understand and be able to discuss it. I want you to leave here discussing it. I mean, heck, if we get in an argument here about it, I'd be okay with that. You know, I got the clicker, so I win. I just win right there. No. But we should be talking about having these discussions. And there may be things that are, I don't know, maybe they're provocative, maybe they're not. Maybe you just, your own point. I love that about our state. So 3 things. The prevalence of hemorrhagic shock. That's an epidemiological word that means how much of this stuff happens to people, and is it a problem worthy of our concern? How big is the problem? And then we want to talk about several examples of the mechanism of injury associated with hemorrhagic shock. Right now, as soon as I say the MOI associated with hemorrhagic shock, you probably either flashed up the last car accident you went to, or you're thinking about some weird thing with a bear or a pipe. I don't know. But you all have your thing. You've been to it and seen it, or read it in a book, or the last picture you saw. I'm thinking about Baltimore shock trauma and the guy who attempted to commit suicide and blew the front of his face off. That's what I think about when I think about it. He's massively bleeding, he's very injured, and it's just, there's a lot going on with that story. But I want to talk about mechanisms of injuries leading to hemorrhagic shock. We do want to talk about, one of the main points we want to talk about is the pathophysiology associated with the lethal triad of trauma. If I show of hands in the room, how many people have heard that phrase, lethal triad of trauma? Not a new idea to you. Good. Others, this may be the first time you've heard this concept or idea, and it is foundational. If you don't believe the lethal triad of trauma, or I've heard it called the lethal triad of shock, if you don't believe that that's what kills people when they get hurt or injured, you will naturally not address those things. And by not addressing those things, you're not going to help them. They're going to continue to have high mortality and continue to have high morbidity. And then the last thing is we're going to talk a little bit about emerging science surrounding maybe what we should be doing in EMS. And I got to tell you, some of it's not that emerging. There's some dates are like 1987. And it's been there. It's been sitting on a shelf somewhere. We just didn't grab a hold of it. And some of it's been going on for a long while because the studies are big. But some of that stuff should be directing our pre-hospital assessment and management of severely injured people. And yet, I've worked in systems or visited systems and participated on different levels in systems all across the United States. And by and large, we still take care of trauma patients the same way we took care of them in 1987. Candidly, he smiled. I'm clicking my imaginary clicker, John. All right, so let's talk about shock briefly. You've heard this before. Shock is a general state of low cellular perfusion. Low cellular perfusion. It's associated most commonly with cellular hypoxia, not enough oxygen getting to your cells. I like to talk about the toenail cell or the thigh cell. You know what I mean? Downstream. We got to get from out here air to in there air. And if we don't, then we don't have good, can't make energy. I gotta look at my notes on. So hypoxia, lack of oxygen, let's talk about that for a second. It's going to be important later. Around the room in an orderly manner so that Cyberland people can hear. I don't think you have to talk that loud. It'll pick us up. What's one cause of cellular hypoxia?
Asphyxiation.
Like somebody choked you out, like a clothesline around your neck. What kind of asphyxiation?
Suicide.
Yeah, they hang themselves. Some kind of squeezing off of the airway, the upper airway. Yeah. What's that?
Oxygen carrying capacity.
For whatever reason, there's plenty of oxygen around, but you can't get it dissolved into your blood or attached to hemoglobin and move it to where it needs to go. Yeah. Low oxygen
Carbon
content.
monoxide poisoning.
Something that displaces the available oxygen, like carbon monoxide or methemoglobinemia or something. I can say that again real fast if you want me to, but I can only say it twice correctly. Methemoglobinemia, that third time is a wash. I can't make it. But if you don't know what that is, it basically changes the affinity of hemoglobin from oxygen, shifts it to something else. You had one?
Oh, that's exactly what I said.
Were you going to say CO or methemoglobinemia? See, I couldn't
That's
quite.
what I was excited.
Yeah.
So in webinar land, we have embolism and drowning.
An embolism, which we refer to as like a VQ mismatch, perfusion mismatch. Air's getting into the alveoli, but we can't get into the bloodstream, or the bloodstream's making its rounds past the lungs, but the air is not there to be onboarded. So some kind of pulmonary embolism or VQ mismatch. Good answers all lead to hypoxia. Whatever the source, all causes. We just named a bunch of them, and there's other ones. Whatever the source, if you switch from an oxygen-rich environment, aerobic respiration at cellular level, switch off the oxygen, what are you going to switch to? Anaerobic respiration. Now, mathematically, this is important because we need those oxygen molecules to make energy. So not necessarily the oxygen itself that's that important to us for life. It's the ATP that's generated through the, the glycolysis, the Krebs cycle, the electron transport chain to produce energy. So we don't care how much money is in our bank account. You know what I'm saying? That's not important to us. The important thing is we get to go and do the stuff we want to do. I want to have a four-wheeler. I'm on the market for a Ruger 4. What am I looking for, Chris? 44. No, I'm looking for a Cazoo, a 457. 454 Cazoo. See, I'm just getting started, right? Because I'm going to go hiking and I might have a bear attack. I'm new to Alaska and I'm scared of bears, so I don't want to. I'm going to kill every bear. And I got kayaks, I want to do that, and I want to do the stuff I want to do. Get up and go, make pancakes. I don't really care how much money I have in the account. It's not about how much money I have in the account, it's about how I want to do the stuff I want to do. And that's the economy of oxygen and ATP. It's not the oxygen so much, it's how much ATP we can get going so we can do stuff we want to do. Like, breathe, have a heartbeat, live, things like that, real basic stuff like that. So in the aerobic cycle where we have oxygen, the economy is basically one glucose molecule equals 36 ATP. It's an incredibly good investment. Warren Buffett would like this investment. One molecule of glucose, 36 ATP. Aaron Streeter is a registered nurse. He has calculated this in his head, and he's about to tell me that I'm off by 2, because I'm always off by 2. 2 of them get used up in the process. Okay, sorry. You get the idea. Forgive me for my mathematical skills. However, if you enter a hypoxic state, you will naturally switch from an aerobic respiration, an aerobic economy of ATP, to an anaerobic economy of ATP, and one glucose molecule only equals, does anybody know? Dose. Dose. That is Greek for 2. That is French. No, wait, that is Mexican. That is Spanish. It's so offensive to all cultures right now. No. Two ATPs created from one molecule of glucose. Is that enough? Huh? If you're completely still and don't need to do things like, I don't know, extravagant things like breathe and have a heartbeat and have a body temperature of 98.6 degrees, which is a byproduct of using ATP. Heat is generated when we use ATP to do stuff. Then 2 might be enough for a minute, 30 seconds. All right. 2 might not be enough. We might need more. So that's the problem. That's the problem with going into an anaerobic cycle, with shock, with general state of low cellular perfusion. As you end up in a bad economical equation, the payoff is bad. 1 glucose, 2 molecules of ATP. The other thing that's associated with this generally low cellular perfusion state is increasing levels of acidosis. There's a problem. Because the minute a body thinks we're going into anaerobic mode, it starts looking for other sources of fuel to replace, supplement the glucose. And what does it find in there? Lipids, fats, bad stuff. And when we try to break that stuff down and burn it, try to burn it, what do we end up with? A bunch of bad waste products. We can deal with some salts, we can deal with some water, and we can deal with some carbon dioxide as the normal waste products of aerobic respiration. We just really cannot deal with it. It's hard on our body to deal with a whole bunch of lactic acid as the byproduct of really bad cellular respiration. So, click. That sounds awesome. We're getting good at this, John. All right. So let's differentiate a little bit. So any questions about shock in general? Right? We know it comes in many forms. When I was a wee paramedic, they taught me that acronym shrimp can, sepsis, hemorrhagic shock, respiratory shock. I don't even think we have that one anymore. Insulin shock, metabolic shock. Remember that shrimp can? We don't talk about it that much anymore because we break it down in a different way, but it's the same kind of stuff. But we're going to talk about, now we're going to narrow this down to hemorrhagic shock tonight. Last month, Dr. Quigley was talking about sepsis, septic shock. What's the problem with a patient in septic shock? Essentially, 2 problems.
Third spacing.
It's in the class distributed shock, and the fluid is lost, primarily plasma, not red blood cells, but primary plasma, into third spaces that it's just kind of like, I'm not here, I'm not there, I'm not really useful, I'm just here making things bloated. I got a little distributed shock in my mid area. And then what's the other problem? Big dilated blood vessels. It's a relative hypotension because you don't have any more fluid, but you got big pipes. How many firefighters you got in the room? If I give you a fixed amount of fluid and continue to make the size of the hose, the diameter bigger and bigger and bigger, what's going to happen to pressure? Pressure's going to drop naturally, right? So shock is brought on by bleeding where you actually lose the blood components, like, for example, red blood cells, platelets, clotting factors, plasma, all that stuff is gone. It might be gone outside of the vascular space, inside your belly, your pelvis, your chest, inside of a femur, or it could be spilled out onto, dripping down the elbow of your lover's hand, I'm making the psycho kind of, how would you describe this? There's no video. I have to describe everything. But I joke, and it's very inappropriate, but that's the dark side of EMS. Or it could just be spilled out on the sidewalk or in the foot of the car. Bleeding, external bleeding is what I'm talking about. So let's talk a little bit about mechanism of intrafemoral. I'll start it off, and we'll take the air out of the room. IEDs and gunshot wounds was where the MATTERS study, which we'll talk about later, it's a military study looking at something called TXA. That's a spoiler alert. Is a big one. Because if you get blown up, whether it's from the blunt force of the pressure wave smacking you and, ripping your liver open or causing blunt trauma, or shrapnel being thrown at you and piercing your body in a penetrating trauma way, or you get shot, there's a lot of blood loss involved. So soldiers put themselves specifically in that kind of harm's way on a regular basis as part of their job. So naturally, the patients that we look at from the military are IED guys, and they got blown up and shot. They also have falls. Other mechanisms we see in Alaska, MVCs, right? I'm disturbed by the number of ATV and snow machine accidents. I used to say snowmobile accidents, and a friend of mine who works for the Alaska Railroad, he can't get any more Alaskan than this guy. He drinks drinks with a frozen toe in it from Dawson City in the Yukon, and he drives a snow machine 200 miles in the dead of winter to get it. I call him Mr. Alaska. Mr. Alaska told me that they are not snowmobiles. A snowmobile is something that a little teeny tiny baby Alaskan looks at going round and round when he's dreaming about his first snow machine. So, but I'm alarmed by ATV and snow machine accidents in Alaska, and I have taken many asides. I will take another aside here and say to you that we can sit here all night and talk about trauma care, and we're not going to move the needle on survival until we stop that conversation and start talking about accident and injury prevention in the state of Alaska. There is not enough people, not saying enough, not loud enough about helmets. Helmets is like saying gun control to Alaskans. I'm sorry. Everybody just hung up. All the people just hanging up on the thing right now. Cyberland, everybody's walking away with their hands up. No, we don't talk about helmets. We don't talk about operator safety enough. We don't talk about safety signage enough. We don't talk to landowners enough about how I've been by private property that's near these HEV tracks that are all around, and I've seen cables with no ribbon, no marquette, no clearly visible thing, just strung between two trees on these paths. I mean, holy cow, you take a 13-year-old kid who's got zero judgment, probably going way too fast, and he goes into that, what's going to happen? It's going to be cut in half. And that has happened in the state of Alaska. We can't, that's not good. We can't be doing that. So when it comes to that kind of stuff, I challenge you all as part of your profession to become preventionists. We're going to talk about being resuscitationists tonight. But as much as we are resuscitationists, we should be spending 10 times more time on being a preventionist. Because you can get there quickly in some situations and have the best tools and the best science, and you know what they're going to be when you get there? Exactly going to be dead. And the only way to get them back is to get in the time machine and go backwards to the prevention activity we should have been doing as a general rule, day in and day out. Just like the fire department talks about smoke detectors and fire prevention, and they have little kids crawling around on their belly in the classroom, and they got those cool little plastic hats. I love those hats. I take one every time I go to the fire department. You know what I'm saying? They've got that figured out. And then I go to work up there, and I have firemen sitting on one side, EMS sitting on the other. There's no EMS guy sitting on the other side. That's ridiculous. They're out running calls. Fire department, chilling. There ain't no fires. I mean, there's going to be fires. Hopefully there's not going to be any fires, but there's going to be some grass fires and stuff like that because it's dry. But they spent 100 years doing fire prevention, and they get to watch the football game on Sunday. I mean, let's think about it. It's about saving lives, eating pancakes, watching football, by God. Let's get this done. All right, back on track. Other trauma native to the Alaskan experience. Bears. That was self-motivated. Have not had a bear encounter, not a real bear encounter. And so I'm nervous about my first bear encounter, but I know that there's a story this year, I think 2 already actually this year, of a Denali bear attack that ended up at the hospital in the valley in Matsu. 3, you know of 3?
And they've been flown.
They've already been flown. Yeah. So that's a real mechanism of injury for trauma in Alaska.
Denali up in Kotzebue and then down in Sitka.
Right. Did all these survive? All survivors?
2 did I know. I think all 3 have survived.
Were they any of them hiking with their family, just minding their own
Probably.
business, having a
That's
picnic?
when it happened. Yeah.
The Sitka one, the guy, the only reason I know this much is because I know the people who flew him. He was camping with a group of friends, bent over to fill up a water bottle, heard a stick break, and about the time he stood up, the bear was probably 30 feet away, just full bore at him.
Was there any chance, had he been wearing a 454 Kasul, would he have been able to get any around?
They were on a bear hunt.
It made me feel better though.
Tripped him up pretty good and then jumped literally through his campsite over their fire and took off.
Wow.
Yeah.
So trauma in Alaska, bears, falls. It's still the #1 mechanism of injury in the United States and in Alaska, falls. Now I'm talking about all types of injuries and accidents, from the non-acute fall all the way up to things that kill you, kind of falls, or injuries. And so falls is #1. Chainsaws, there's a professor at the college. His name is, it's a fantastic name. Are you ready? It's Pete Pretorius. He should be writing a book, Dr. Pete Pretorius. And he's writing a book on chainsaws as a mechanism of injury. He's a communications major or professor. But we got stuff like that because frontiersmen are working and doing stuff. And, you know, I watch TV. I know what happens in Alaska. They're hoisting and chopping and moving and, right? Am I wrong? No, that's not how it is. But there are many various unique, and some of them not so unique, like falls, problems in Alaska as far as trauma. And then we can't miss this. If we're going to talk about hemorrhagic shock, we can't skip over nature of illnesses related to hemorrhagic shocks, because there are those people bleed to death from things like OB bleeding, whether it's postpartum or whether they just have bleeding, and then GI bleeding, which is kind of there's a lot of people with GI bleeding. I don't know what the prevalence is, but that might be germane to the conversation as we go along talking about how to manage hemorrhagic shock. You might have to get out of your trauma thinking cap and go into that. I clicked it. All right. So what's the prevalence of fatal hemorrhage in the United States, in the big whole United States? You know that trauma is a leading cause of death in ages 1 to 44, right? Did you hear that before? It's not new information. That's a fairly young group, and the reason that I think it's the #1 cause of death in ages 1 to 44, I am 44, so the chance of me dying from something traumatic is going away. But the good news is I'm going to die of a heart attack because I eat too many cheeseburgers, and I teach paramedic students who are vengeful people, and they live in the valley. So I'm probably going to die from a heart attack on purpose. It's going to look like they're trying to save me, though. You're going to make it convincing.
There's a couple around in
So for that group, it's the leading cause of death, trauma. But for all ages, young to old, it's the 3rd leading cause of death. You want to know #1 is cardiovascular disease, too many cheeseburgers, and sitting is the new smoking. And cancer is #2. And probably the reason cancer is #2 is because the healthcare system's very, very good now. We keep people alive longer, and they live long enough to develop a cancer. Nationwide in 2002, 161,269 people suffered from fatal traumatic injury, and the reason I put that number up there is because that's 56 individuals per 1,000 residents in the United States. I'm going to give you some more numbers in a minute to compare to. 40 to 50% of all those people had a head injury or broke their neck, had a CNS injury. 30 to 40% of the people had a fatal hemorrhage. Now, we could have this conversation about head injury and TBI. We could, because its prevalence is higher than hemorrhage, and we should be talking about how to take care of those people and how to make their outcomes better, but we're just not. We're talking about, I get to choose, so I chose hemorrhage. I put it in red, it's not invented. All right, let's click the thingy. Now, oh, I got to give you data for Alaska. I said, that's interesting, but I learned from being here that the worst thing you can say to Alaska is, that's not what they do in the lower 48. Oh, boy, you get some hurt feelings when you say that. So I thought I would share with you what kills Alaskans. Remember, 56 out of 100,000 individuals is sort of the prevalence number for trauma in the lower United States. What do you think is the leading cause of death for Alaskans? My students know it because the lady told us. It's cancer. What do you think is #2? Heart disease. Yeah, just flip over. Just flip over. Yeah. But here's the one I want to talk about. #3 is injuries, just like in the lower United States, the other United States. And listen to this number: 71 out of 100,000 people die from accidents and illness, accidents and injury in Alaska. Remember, the number for the U.S. is 56. So for our state to be, it's really 20 percentage points higher in prevalence, 56 to 71. Am I doing that right?
It's like 27.
Yeah, it's almost 30 percentage points higher than the state. That's a difficult pill to swallow. I go back to prevention, and I will say if anybody in the country should be having this conversation about managing for trauma patients for improved outcomes, it should be us because of our prevalence. Period. Move on. So that slide. Don't move on. Ready to go. So we got to review the pathophysiology of hemorrhage. It may have been a minute since you looked at it in your EMT curriculum or your paramedic curriculum or EMT 2 or 3 class. Naturally, the the instigating problem with hemorrhagic shock is loss of red blood cells, right? Because when you lose those cells, you're probably losing volume with it, right? They didn't just jump out of the plasma and walk in a single file line like ants down your arm. They ran out, like from the faucet for a second. And that got rid of your O2 oxygen capacity. So you got two problems there. You got a volume problem and you got hypoxia essentially, right? It's also associated with low circulating blood volume because you're going to lose plasma. That's going to lead to decreased cellular perfusion, which we mentioned before was the cause of shock. And then that activates this stuff, which I want you to think about in a little bit deeper terms, vasoconstriction. The purpose of vasoconstriction is to compensate for what? It's on the board. Low blood pressure. Right. When the brain and the heart and the kidneys start to realize that their perfusion pressure is dropping, they naturally kick in a series of mechanisms to bring that blood pressure up so that they get to win. Screw you, feet, hands. We're going to stay alive no matter what. We will be bobbing around without hands and arms, but we will win. Tachypnea, compensatory mechanism. Why? Cellular hypoxia, right? The body tries to fix itself with what's available. So breathe faster, get more oxygen in, moving around. Even though there's no red blood cell carrying capacity, that's still the trigger that's triggered. Bring more oxygen, bring more air in. Hopefully the air that you're bringing in has oxygen in it. And tachycardia, compensatory for what? Cardiac output, right? Cardiac output, what's the formula for cardiac output? Cardiac output equals stroke volume, the amount of blood that's squeezed out with one pump over a minute. Yeah, heart rate times a minute. And then blood pressure is that number, cardiac output, whatever that number is, times how tight the pipes are, systemic vascular resistance. So those very simple equations that you learn in EMT school are behind the compensatory mechanisms that drive the pathophysiology of the bleeding person. Just as a note, the capillary sphincters, the small blood vessels can constrict, but the capillary sphincters, the smallest blood vessels, the 1 cell diameter blood vessels that let RBCs flow through, they can't. They cannot constrict. They're as small as they're ever going to be. They have these sphincters before and after each cell that trap blood in the middle when they feel like they're threatened for resources. Capillary sphincter constriction. And that's a good thing in a way if the situation is temporary. You know what I'm saying? If the resources are in low supply temporarily, then that capillary sphincter thing is good. If it goes on and continues to go on, what does that become in between those two capillary sphincters that's building up as a result of anaerobic respiration and the production of lactic acid? I call it a cesspool. A cesspool of waste product building up in a little teeny tiny spot in thousands of places across your body. And when you don't have any energy to keep those sphincters closed anymore, what's going to happen to that stuff? It's going to dump into your, yeah. That makes the situation worse. Let's click the button. All right. So we talk about the compensatory mechanisms associated with pathophysiology of hemorrhage. Let's also talk about the coagulation cascade. I have felt like in my career that this is something I had nothing to do with. I can't make people clot from the inside. Do you know what I'm saying? I can do direct pressure, I can put on a tourniquet, whatever, but I can't not make people clot from the inside. Well, you can't. You know, I don't have, that is a tool that is not in my pre-hospital toolkit. But it turns out that the body's trying to clot, and we can support or make it more difficult for that process to happen. So what happens in the activation of the coagulation cascade, which is part of the pathophysiology of hemorrhage, is you have an initial, you cut your finger, let's call it simple. You have an initial inflammatory response. That leads to redness and swelling and all those things that trigger the whole thing to get started. You have local platelets, which are just hanging around. Fragments of old cells floating around waiting to clog a hole. You know what I mean? Then you have a coagulation cascade, which recruits red blood cells to that area and more platelets to that area, and then promotes and stimulates the production of fibrin, which is a bunch of sticky fibers that kind of bind that clot together and form a stable clot. Without the fibrin, your clot's not stable. You change the pressure, you change the flow, you change the size of the hole, you change anything, that clot's going to get washed away, moved away. Remember that I said these clots get washed away because I'm good at that. I know how to do that. Formation of a stable clot is the final product, and we hope that it stays there long enough, the clot stays in place long enough so that we achieve something called hemostasis, not homeostasis. You know what that means. What's hemostasis mean? So a return of the pump and the pipes and the fluid to a normal state that can meet cellular oxygen demand, cellular perfusion demand. That'd be hemostasis. Intact blood vessels with enough blood inside of them that's moving around in a big circle, that's hemostasis. And hopefully the clot's stable enough to do its job until things get returned to hemostasis. But if it goes on and on, or if bleeding is too widespread and too severe, you can never achieve hemostasis, and so those clots sometimes break up and leave. Which leads me to this conversation. This is the whole reason I wanted to come and talk to you tonight. This idea of the lethal triad. If you've heard it before, then this is somewhat review. If you've not, this could be the most enlightening thing you've heard in trauma in 25 years. What kills people in trauma is not their blood pressure. People who are bleeding, it's not their blood pressure that kills them. I was having this conversation with a colleague this afternoon. We were talking about this idea of if everything is a nail, if every problem is a nail, then every solution is a hammer. And what we've said, the moment you step into your ETT class and your EMT class, one of the basics, first skills you were taught was what? Take a blood pressure with a sphygmomanometer blood pressure cuff. And I've been watching students wind up blood pressure cuffs, because you have to spin them around 3 or 4 times to get them to work. You wind them up a couple times to get them on right. I'd do it too. They're looking at me like, I don't do that. I'm perfect with that. No, I'm not. You get it on upside down, backwards, inside out, the Velcro stuck to something else. You got to wind it up for it to work. It's like one of those little toys with the feet that walk. You got to crank it up. We taught you that in ETT school. We taught you that in EMT school. We talked to you about it again in EMT2 or EMT3 or intermediate school, depending on where you're from. And then when you became a paramedic, we went one step further and put you through ACLS and talked to you about, you became a paracardiologist in paramedic school. And so a big part of all that education and learning was based on the patient's blood pressure, the patient's heart rate, the patient's respiratory rate. So we made blood pressure become this number, this metric that was right in front of you all the time. You're supposed to check it every 5 minutes in unstable patients, are you not? You're supposed to check it every 15 minutes in a stable patient, are you not? Yeah, we told you that. You should do that. It's a good thing to do. You should. But that is not what's killing your trauma patient. You still got to know how to take a blood pressure. No one's getting by on that. You still got to do it. You do got to not wind up the blood pressure cuff, though. I can show you how that works. Classes from 8 a.m. to 5 daily. What's killing our patients in trauma is this right here. As soon as they go into a state of low cellular perfusion, and as we've already talked about ad nauseum for pathophysiology, they immediately become one of these 3 things or 2 of these 3 things, or if the bleeding is massive enough, quick enough, they become all of those 3 things. So what's the lethal triad? You can click it. Acidosis. I've already alluded to this. It's brought on by anaerobic respiration, which I consider metabolic acidosis. When the acid that's entering your bloodstream is coming from the cellular level, the kidneys aren't doing their thing, the cells are kicking off too much lactic acid like we talked about in anaerobic respiration, then that's metabolic respiration. But is metabolic acidosis the only source of acid in a trauma patient? What if they've got a pneumothorax? What if they just got pain? I fell off my roof and broke my ribs. I won't get into it. I would love to get into it. It's a fascinating story, and my students love to hear about me being in pain. You look like a man who's taught people before. Yeah. They want to hear about your struggles and your strife. And so I fell off my roof and broke my ribs, and I was in pain, and I was breathing like 40-something times a minute, as shallow as I could, because I felt like the devil had rammed a horn into my back. And that right there, that's hypoventilation. You say, wait, no, he's breathing fast. That's hyperventilation. No. If I'm taking really, really shallow breaths and breathing 50 times a minute, I'm not moving enough air volume in and out to get the carbon dioxide that's building up in my tissue, probably just from pain The physiological response to pain is to increase cellular metabolic demand. So anyway, I wouldn't hurt that bad, but I was breathing fast. I was already starting to become acidotic because I was hypoventilatory. Again, breathing fast is not hyperventilation. So you naturally become acidotic when you become injured, typically. The degree to which you become acidotic will depend on the severity of your injury and the mechanisms associated with it. Do you have metabolic acidosis because your body is trapped under a heavy piece of equipment and you're in a general state of cellular low cellular perfusion? Or is it because you have a respiratory component causing acidosis, respiratory acidosis, like a tension pneumothorax or flailed chest or sucking chest wound or some terrible thing like that? Or both? Hemopneumothorax and you're bleeding and you've got a respiratory component. You're going to start to go into this acidotic state pretty quickly from the time of the onset of injury to what's an average response time for you guys? 8 minutes, 12 minutes, 15 minutes, 32 minutes. I responded from Wasilla to Willow. Lights and siren. I forgot why I was responding. 34-minute response. There was ice on the ground. It was not good. It was night. I don't know how to drive at night. Number one, that's from Alzheimer's. And two, I don't know how to drive on ice. And so by the time I get to Willow, 34-minute response. I literally forgot why I was responding. Well, in 34 minutes, from the time of injury to 34 minutes, if the person's injured enough, you can be in a serious state of acidosis. Lethal triad, leg number one. Hypothermia. The result of a fight or flight response to pain or injury is what? What happens? Heart rate goes up, that's compensatory. Your blood vessels constrict, that's compensatory. We talked about that already. And then for some reason, some old school genetic reason that I can't quite explain, you sweat. We're trying to cool down what should be a metabolic machine that generates heat. Like if I'm running from a bear and I'm not injured, you know what I'm saying? The stress response is supposed to kick all of my capabilities to the next level, which means I should produce more heat in an aerobic system, right? So I need to be cooled down from all that energy that I'm using. That's why I'm sweating. But if I'm injured and I'm bleeding and I have a fight or flight response, am I still going to sweat? Am I going to be diaphoretic? Am I going to be clammy? Well, what happens when a clammy person starts to evaporate perspiration off? You get cool. What happens when you don't send 98.6 degree blood to all of your extremities all the time? Those extremities get cold. You immediately start to go into, you're immediately becoming hypothermic the minute you're injured. The poor ATP payoff, and then obviously the fight or flight response, as I said before. You can click it forward, John. Last part of the lethal triad. Make sure I'm not missing is coagulopathy. It'd be nice if you cut your finger and a clot was formed and that clot was stable enough to last long enough until hemostasis was returned to normal. But in a severely injured person, whether it's penetrating trauma or blunt trauma or any one of those other mechanisms, if there's enough ruptured blood vessels, damage to the container, now you're asking the system to be on, its highest performance level. And what's going to probably happen, the rate limiting factor is probably going to be, is there enough platelet material to clog all the holes that are in you, or the big hole where blood is just pouring out? Imagine platelets trying to stick to that. They're just going to be swept away in some cases. It's gone on the sidewalk or in your pelvis, not doing any good. And do you have enough, do you also have enough of the clotting factors in the clotting cascade to continue to stabilize clots with fibrin? And if you have big enough injury and enough bleeding, that can't happen, that normal process. It's overwhelmed by the normal process. So coagulopathy, it develops. That's the third part of the lethal triad. A couple things you need to know about coagulation. Under normal circumstances, your body's ability to form clots and to coagulate correctly works best between pH 7.35 and 7.45. That's your body's normal pH. What is not normal about the injured person?
Everything.
The other side of the lethal triad, acidosis. Now that's working against coagulopathy, which is already under stress from a massive. It's like saying If I tried to get you, one of you up out of your chair right now to walk with me down the hallway, I could probably do it pretty good. But if I tried to get all of you to get up at the same time and get down the hallway, it would be problems. System resource problems. We couldn't do it. We're not coordinated enough. And that's the problem with coagulation and massive hemorrhage is too much system resource use, not enough resources to meet the demand, is what I'm trying to say. Another thing you need to know about coagulation in the body is it works best under ideal circumstances when the body's normothermic. What does that mean? The temperature of the body should be about 98.66 degrees, and I always say, is it 34 degrees Celsius? Anybody love 34-ish or 36? 36 degrees Celsius? All right, so I like to throw a nod every now and then over the pond to the Celsiites, but about 36 degrees Celsius. What's the problem with the person who's in a fight or flight system, fight or flight response due to trauma? They're already starting to become hypothermic immediately just because of sweating. See what I'm saying? So now that's going to push back. The other side of the lethal triad is now pushing back against this coagulopathy thing. And what we need most is to not bleed. That would be ideal. Get that under control. When the hemostatic demand is normal under normal circumstances, we have more than enough resources. I cut my finger. I cut myself shaving. Do you know what I'm saying? We have more than enough resources between vasoconstriction and all the compensatory mechanisms, the available clotting factors, platelets, fibrin, and all that stuff to stop that. But when the problem is big, there's not enough resources. And that's a problem with coagulopathy. So acidosis, hypothermia, coagulopathy. You've got to believe, before you click the slide, John, you've got to believe that that's what kills trauma patients. If you don't, you won't do the right things to prevent their mortality and morbidity or reduce it. Do you understand where I'm coming from? If you don't believe this idea, you're dismissed. I tell my students all the time, I don't have an opinion about this. I didn't make this up last night. I don't have an opinion about anything that I choose to treat. I have evidence. Powerful, strong, I was going to say unaltering, but next year they'll alter it. Evidence. It's the best thing I've got right now to make clinical judgments in the field. And I go through the painful process of reading and keeping up with it and trying to understand it and how do I apply it as a field provider. And then even worse, how do I tell these guys, like, well, I'm telling you right now what it is based on the best new evidence, but it's going to change in 10 minutes. And so you better be watching for it and be ready for it so that your outcomes improve. We want your outcomes to continue to improve. We want to continue to get better, continue to get better at it. Some people are like, I don't know if I want that or not. You do want that. You do. Let's talk about assessment and management. Big review. It's Con Ed. It wouldn't be Con Ed if we didn't review stuff you already knew. Okay? Scene size up. Don't forget scene safety. Follow me. This is going somewhere, I promise you. There may be another story about my childhood coming up. I don't know. Scene safety. No good to anybody if you're the one suffering from the hemorrhagic shock. I went on a call in Johnston County, North Carolina. It's as country as it sounds. And we go in the door, and there's a guy in there in these big, bulky sweatpants. He's got his hands in his pockets. We knew him. I've been there multiple times. A known diabetic guy. And he's pale, and he's clammy, and he's kind of out of his mind, talking crazy. And we've been there, and I'm like, hey, dude, you know, calm down. We got you. He's already getting the P50 out and route. You know what I'm saying? We get inside the house. He's just acting a little weird and a little crazy and stuff. And then he discharges around. He's got a .22 handgun in his pants, and he pulls the trigger and discharges around in his pants. I mean, scene safety is not always about power lines being down or cars precariously perched on Pioneer Peak. Yeah, that was an alliteration. I put all those P's in there on purpose. Park panic precariously perched on Pioneer Peak. Anyway, it can be about the mundane, about the things you're not expecting, when your head's not on a swivel, when you're used to the situation. Sometimes that can be the worst scene for you. You know what I'm saying? Situational awareness is the word I like to use. After you determine that the scene is safe, you want to try to determine what the mechanism of injury is, because you want to get some idea what kind of energy has been transferred into this human being's body. Now, we used to be, everything was mechanism of injury. The mechanism was this, so I do that. That is a broken idea. You are healthcare professionals. You're supposed to say, the mechanism is this, So I keep that in mind during my very good assessment of the patient. And then I do things because I think it'll improve the patient's outcome. See this, do that, that's gone. I don't want to talk about that anymore. I don't want to have that conversation anymore. I don't want to be sort of like treated like a junior grade healthcare professional anymore, ambulance driver, trauma junkie. But that's not what I am. It's way more complicated than that. Mechanism of injury, keep it in mind when you're doing your assessments. You can kind of understand the energies involved, and then do things that, based on science, will improve the patient's outcome. You need to know how many patients you got, because you might be, go back one more, you may have resource issues and you might need special resources. I mean, you know, but wow, in Alaska, you got to think early, you might need some resources. Do you know what I'm saying? I was thinking on the way to Willow, 34 minutes into Willow, I did think about that. I forgot what kind of call I was going on, but I remembered that I might need a helicopter in Willow for everything. The sepsis patient, the cardiac patient, the trauma patient, the, you know, for me, I'm old, I might not make it back. My birthday might come before I get back to Matsu Regional from there. Helicopters. So you're trying to form a general impression after you've done all those things, and you want to just make, are they sick, are they not sick, are they not yet sick? And so what 3 things are you looking for in your general impression? Skin condition. I'm saying skin condition, hoping that you think back about the compensatory responses associated with fight or flight, because if you walk up to somebody whose skin is pale, cool, and clammy, this is right out of the textbook, they are by definition in shock. We call that appearance shocky. I'm not sure that's a word. I tried to type it out for this presentation, and I didn't know if it had an EY, or was it just a Y, or an IE, or a shock E, like a rapper, you know, shock, capital E. So I don't know if that's a word. But anyway, we say it, they look shocky. If in your general impression your trauma patient looks shocky, what do you already know about that person from a lethal triad standpoint?
Hypothermia.
We already know they're heading towards hypothermia because that sweat's got to go somewhere. You know, in Alaska, it could freeze on their forehead into droplets of sweat. That also would make them hypothermic. But it could evaporate off on one of these May days where it's 80 degrees. I didn't sign up for that. Just lodging a formal complaint with the Southern Region EMS office and whatever authority you have. There ain't no air conditioner in my house here in Alaska. It was 80 degrees or something. I was like, where am I at right now? It's May. It's supposed to be snowy. Anyway, they're hypothermic. If they're tachypnic, what do you already know? What's that? They're already in compensatory mode. They're already acidotic. And if they're tachypnic in a cold environment, what else are they becoming? Or hypothermic. And then level of consciousness. That's all part of your general impression. Don't overlook this patient. Because you're going to go and say, they're talking to me. The patient is talking to me. That means they have an airway and they're alert. You know, ABFU, alert. Alert to verbal response, alert to painful response, and unresponsive. And then you're going to say they're conscious, alert, and oriented to their whatever 4 general parameters, time, person, place, and events leading up to the circumstances. Does that mean that their brain is well perfused? Those are not specific tests for cerebral anoxia. Because if the person is saying to you, what happened? What happened? What just happened? You had that patient in a car wreck? Can you call my daughter? Where's my daughter? Can you talk to my daughter? Don't overlook that confusion as a subtle early sign of cerebral hypoxia, because the brain, we like to say this, the brain is the most sensitive organ to hypoxia. That may or may not be true, but it's the first organ that'll probably give you a sign that you're dealing with low cellular perfusion. You know what I'm saying? It's sensitive in that way. All right, we can click it. You're just trying to decide if they're sick, not sick, or not yet sick. What I want you to do, and I'm going to give you some treatment options in a minute that won't contradict this, but what I want you to do in your severely trauma patient is assume that when you walk up, they're in the lethal triad already. Their mechanism's high and they have some kind of injury, bruising, or whatever, just say, oh, they're already becoming a little bit hypothermic, they're already in a lethal triad, let's start doing stuff to make that not be worse, improve their outcomes. So how do you assess your trauma patients? Airway, breathing, circulation, disability, and exposure. In Alaska, exposure means 2 things. It means they could be dying from exposure, and you need to get what clothes you need to get off, you need to get them off so you can see what's going on. And then you need to cover them back up again because it could be hypothermic. I put that C up there in front of A because apparently I can't spell. That is not how you spell simultaneous. That's something else. That's a North Carolina version. But hemolconius means at the same time that you're doing manual C-spine control, also you should be assessing their airway. That guy who's holding their head can tell how well they're breathing, or hear sounds like gurgling or whatever, which leads to respiratory acidosis. It needs to be corrected. You got to do a breathing assessment. You got to assess circulation. There's two ways to do that. One, look at their skin through it. One, look at their skin. Two, feel their radial pulse, and then look around and see if blood is spilling out of them, or if it's filling up the cavity by looking for ecchymosis, bruising around somewhere. How am I doing? Okay. That's the PHTLS Bible version of primary assessment. The principle of this thing is to stay. You gotta go.
I wanted to.
The key is, we're happy because Aaron's about to go deliver a baby. It's not Aaron's baby.
Practice it like that.
It's not Aaron's baby. Anyway, as you find a problem in that process, C-spine, airway, breathing, circulation, disability, and expose the patient, as you find a life threat, just stop right there where you are and fix it, right? Especially if it's a life threat that has to do with a lethal triad, like they have a tension pneumothorax, it's going to lead to respiratory acidosis. If you're able to do it in your protocol, can the EMT3s decompress? Needle decompressions. Paramedics. So there are EMT3s in our state who can do needle decompressions. Okay, good. That's what I'm talking to. That guy and the other paramedic people. Decompress her chest. Because we got to reverse respiratory acidosis. It's compounding the metabolic acidosis of this injured person already. If you see that they're breathing 42 times a minute, and remember, that ain't hyperventilation. If it's shallow, quick breathing, that's not enough tidal volume, air exchange to get the job done of getting carbon dioxide out. Don't be fooled that breathing fast is hyperventilation. But they might need assisted ventilation to give them 1 or 2 big, deep breaths, every, 30 seconds, 15 seconds, breathing 10 times a minute, something like that. Check their circulation, check their radial pulse, look at their skin, and check for major bleeding. And then disability, you need to go ahead and assess and find out what you're dealing with as far as the central nervous system goes to. Do they have a TBI? Do they have a spinal cord injury? Because if they do, I'm going to unashamedly tell you in a minute that some of these strategies should not be applied to that person. If they have a TBI, they exist in another category from the plain old ordinary I'm bleeding to death hemorrhagic shock patient. The only way you're going to know that, if they're not in your category, they're not in the hemorrhagic shock category, is to assess their disability. Look at their pupils, have a conversation with them, assess their spine, check their peripheral CSM, the stuff that we do to find out if someone's brain and spinal cord is intact. Right? That's not what this lecture is about. And then obviously, as I said, expose them, but make sure you recover them back up again. As you find a life threat, fix it. Click one forward there, John. Okay. This is how the military thinks of the same idea for soldiers in the field. If you ever took tactical combat casualty care, anybody ever took tactical combat casualty care through this? Anybody online raising their hand for tactical combat casualty care? It's good medicine. It's down and dirty. Get the job done. But this is how they think of it. When they approach a wounded soldier, probably the thing that wounded the soldier, the threat that created the casualty, still exists. So the thing that's not up there in March is security. The best way to treat a wounded soldier is to return fire. Win the battle. Defeat the enemy, because if we can't get the soldier to surgery and get him out there and get him evacuated and get all the things that we think we need to do in EMS until we win the battle. But once that's being taken care of, the military thinks that the first thing you do is look for major bleeding. Why do you think that they put that at the top of their acronym? Because they bleed to death. That's what kills them first. And then, way back when they were teaching combat lifesavers to do IVs and give fluids and all this fancy stuff, and they were not putting on tourniquets, and they were not plugging up holes, and they were not, doing direct pressure. But soldiers were literally bleeding to death because they had big head lacks. Not head injuries, big head lacks from shrapnel. And your head's really got a lot of perfusion, you can bleed to death from a big head lag. They have an IV. Bled to death from a head lag. And then they look at airway, same as us, respirations, that's just breathing, right? Same thing, they look at that, and then decide if they need to do a needle chest here or bag patient or whatever, and then they look at circulation. They want to see how well their heart's beating, if they have a radial pulse, kind of generally what their field blood pressure is, and then they want to assess their head. And the reason they assess their head is because of what? If the patient's a TBI, then the management and care that they're going to get, even in the battlefield, is not the same as the guy who's bleeding to death. So they want to make sure he's not a TBI guy, because he's going to go in a different direction. So that's just another acronym to throw your way, MARCH. And if you get into a conversation with really experienced and skilled operators like Aaron, and you say, yeah, MARCH, T-CCC or whatever, then they're like, whoo, they're looking at you because you're talking their language. You know what I mean? And I don't know if you notice now, we have a bunch of these guys around here. These J-Bear dudes, we got some smart people working on this base that know about how to take care of injured people. All right, next. So, what are the key principles in the management of a severely injured person who's bleeding to death? Number one, should be a big, loud duh sound forming in the room right now. Hemorrhage control, you got to stop bleeding. We've got to aggressively manage major external bleeding immediately, without delay, without hesitation. Why am I saying that? Because I see EMTs come to our program who got taught airway breathing circulation, and they'll leave a bleeding to do airway. That ain't going to work. That won't work. Some of this, we teach it in kind of an order, linearly, but it probably is happening more asynchronously or simultaneously if you have more responders. But we got to do a good job of getting control of major bleeding, so much so that there's an emphasis, you may have already caught wind of it, there's an emphasis right now going on in public safety and in EMS about bleeding control, stopping bleeding, hemorrhage control. There's tactical first responder classes and tactical emergency casualty care and that kind of stuff. Because as a rule, the layperson doesn't know what to do. They do peekaboo with bleeding. That doesn't stop it. Put a bandage on it and hold it, and then look at it. See, it's not, look. And that doesn't work. So we got to have these fundamental conversation about direct pressure and hold it down and call 911 and all that chain of survival stuff that we talk about for CPR. We have to have that same conversation for bleeding. So much more so for Alaska, because 71 out of 100,000 people here get hurt versus 56 in the lower 40. The lower 48 never does anything as good as we do. Dummies. All right. So what are the two mechanisms now touted as the primary hemorrhage control measures? Direct pressure and tourniquets. What it used to be. Anybody? Direct pressure, elevate, pressure point, and never, ever put a tourniquet on. I don't know why. Because they were going to lose their limb, I think. Right? Is that right, Lizelle? Don't put a tourniquet on because they might lose their limb.
Right.
Yeah. A dead guy never complained about losing his limb. Living people do, though. I learned that you can make and flip pancakes with one hand. So it's a trade-off in some situations. It also turns out that it's probably not as bad for limb perfusion as we originally thought. So now it's just simple. Direct pressure, I like simple, don't you? Direct pressure, tourniquet. When would you put a tourniquet on somebody if direct pressure wasn't working? After 10 seconds, 15 seconds, 30 seconds, a minute or 2 minutes? What's your time frame? Yeah. A minute? About a minute?
No.
Immediately. You put direct pressure on there and immediately the hemorrhage is overwhelming your galls and you just go to a tourniquet. Mike, what about you? After 1 minute of a trying direct pressure? There's not a right answer, by the way. There's not a right answer.
50 seconds. Get out of the bag. If I
What's
put
that?
gauze on and a tourniquet, get it out of the bag. They're getting the tourniquet.
Yeah. Go down there with your direct pressure, especially if it's extremity trauma involving a big blood vessel. Go down there with your direct pressure as the intermediate step. Direct pressure in your knee while getting the tourniquet out of the bag. That's probably kind of where we're going with this kind of stuff. there's some John Wayne out there right now who is taking the gauze and taping it to his tourniquet in his trauma bag so that it comes out at once. He can do that.
Israeli band.
I like those Israeli bandages. They're not bad. They're not bad. So there's all kinds of ideas on this theme. The Cat 1 tourniquet or Israeli bandages. How about this? 4x4 is an extra strap. You know, sounds like an Israeli trauma band. When you have time, after you've addressed the massive bleeding, obvious external bleeding, don't overlook the less sexy stuff like splinting lung bone fractures, which actually controls bleeding and improves coagulopathy. Splinting lung bone fractures. And then also controlling less severe bleeding, like those scalp laxatives you kind of overlook. They were doing okay in the car, or they were doing okay on scene. Now make sure you get that taken care of too, because every one of those red blood cells counts, and every platelet that's lost counts, and all that blood volume counts. So when you have time, you need to deal with all that stuff. But then here's the big one. They got to go directly to definitive care, which is surgery, for something called, in the new paradigm, damage control surgery. We're just going to, somebody who knows something about probably the abdominal thoracic cavity is going to open them up, fix big blood vessels. It's not going to be pretty. It's not going to be sexy. They're destined for another procedure, but we're pulling all stops to get hemorrhage to stop. This is the primary key principle. What kind of delays are you going to have on scene? Well-trained healthcare professionals that you are. Nothing ever delays by.
Getting them out for starters.
Extrication could take a minute if they're trapped or pinned or something like that. That may or may not be in your control. That's certainly a potential problem. Bears that won't leave the area could be a problem. It all goes back to bears for me. Where are you taking this? A delay in definitive care could be either one of two things. How remote you are in a direct path to definitive care. For example, you've got to get on a fixed-wing aircraft in Bethel to fly to A&MC. That's the closest. Is that a possibility?
Yes.
Definitive care could be that situation.
Yes.
Okay. So that's a delay. Probably not in your control. Here's the more sinister version. You're taken by EMS professionals to a lower level of care that doesn't have the ability to do definitive care, disaster control surgery, and then they do their thing, and then they go from there to another stop. So when you add a stop in the middle, you're delaying the time from the injury to the disaster control surgery. Am I saying the right word? Damage control. That happens to me sometimes. It's a neuronal flip-flop thing. Dementia, I think they call it. But that damage control surgery is important, and what we don't want to do is stick things in between the injury, unnecessary things in between the injury and getting to damage control surgery. What are other delays on scene? It takes time to wind up a sphygmomanometer. You need a blood pressure cuff?
Webinar land, they said adherence to long-standing standard practices, IVs.
Getting an IV on scene. That's a good one. Boarding a person who may or may not need to be boarded because that seemed like the right thing to do. Yeah, listen, time yourself trying to backboard somebody correctly by the textbook. It takes a minute. Getting a blood pressure. Taking a blood pressure takes a minute on scene. All that stuff can lead to delays. And all of that stuff, except for the backboarding thing, can be done while the wheels on the ambulance go around. Now, one thing that should be spinning around and around, your partner will probably be spinning around and around. The sphygmomanometer, you're trying to figure out how to get that on right. But those two things should not be spinning. What should be spinning around and around is the wheels on the bus. Should be going around and around because all that stuff can happen while you're going en route. And I know I know you feel like I'm sort of maybe kind of condescending about this, but it's not the first time I've had this kind of conversation in really well-developed EMS systems, the most progressive EMS systems in the country. And yet, if I check in on the scene, many times I still see really smart paramedics wasting time on scene with IVs and getting them manual blood pressure and stuff that's just killing time. Do you know what I'm saying? Get the patient out, package them appropriately. I'll leave it at that for now. Maybe Lucille will probably never invite me back, but if she does, maybe I'll get to talk about long spine boards and my loathsome distaste for them. Stuff like that.
We also call trauma alert. So we actually identify the hospital. They'll tell us which ones accepting of a major casualty.
Right.
If
So
there's
that
one
system,
or two.
that's a good counterpoint to what I'm saying, because that trauma system was designed with one express purpose: to give the damage control surgeon early notification so that all that preparatory stuff that has to happen in a hospital, wind up in the OR room, get the staff on site, get stuff in place, get blood there, is happening during your transport time. And when you don't call a trauma alert, you're delaying from the time from injury to damage control surgery. Is that what you're trying to say? Yeah, good point. I should say that all of that stuff that's up there, all the ways you care for major bleeding, is confounded by lots of potential problems. The patient's age, where you are, the weather outside. Are they taking Coumadin? Are they taking other medications? Are they a pregnant female? Are they a little baby? All those things confound this, which should intensify the purposefulness with which you move and behave and do. You can click it forward. Second key principle. First of all, fancy technology involved with the first key principle, a bandage and tourniquet, and an ambulance. Advanced technology brought to you from the year 2016. I don't know. Nothing sexy. Get that stuff done. It's just basic work. Get it done. Controlling hypothermia. A big part of controlling hypothermia is, see the previous slide, hemorrhage control, right? Limiting environmental exposure. It's cold in Alaska. We should get them somewhere that's not so cold. Here's more advances in technology coming your way. A blanket. We're going to have to take the patient's clothes off because we need to do that and do a good assessment, but we should quickly get them under cover as much as possible, especially if it's a prolonged extrication outside or some other extenuating circumstances. For example, we call it January here in Alaska. We need to try to conserve body heat as much as possible. Yeah, I'm talking about putting a blanket on them while they're in the car and while you're assessing them. Yes, I'm talking about that. But certainly when you get them out of the car onto the stretcher, they need to go under a blanket, and then you can do the first half of your secondary assessment by flipping it this way, and then you can do the second half by flipping it that way. They'll do the upper body, flip the blanket back, do the lower body, flip the blanket back. And then the one that's the least popular among EMS professionals, because our comfort is number one, 80 degrees Fahrenheit in your ambulance. I just complained about 80 degrees Fahrenheit. My house don't have no air conditioning, and I'm saying I'm promoting that you keep your ambulance at 80 degrees for trauma patients. Yeah, I am. If you're not sweating a little bit in the back of that ambulance, it's not warm enough for you to fight this problem. 80 degrees in the back of your ambulance. Good, no one's fighting. That's awesome. All right, next slide. Next key principle, managing acidosis. Again, I refer you to slide number 1. If you control hemorrhage, if you can manage hemorrhage, aggressively control hemorrhage, you'll go a long way towards preventing that cycle of acidosis that happens in hemorrhagic shock that we discussed before. And then the restrictive use of crystalloid fluids. Why? We're fighting acidosis, and normal saline out of the bag has a pH of 5.5-ish. The reason I say ish is because some of it got measured at 4.6 pH. Just makes my argument a little bit stronger. The pH of lactated ringers, which a long time ago was the choice fluid for trauma, is 6.5. Remember the slide about normal body pH is 7.35 to 7.45? We'll see coagulopathy problems and acidosis problems at 7.3, 7.29, 7.28. So that's pretty dramatic when I'm telling you that the fluids we have on hand are pH 5.5 and 6.5. Restrictive use of crystalloid fluids. I want to make sure I'm clear about what I'm saying. This is emerging evidence. It's not my opinion. It is my opinion. The old fluid resuscitation philosophy was what? 2 large bore IVs, lactated ringers, wide open till you get to the hospital. That's called aggressive pre-hospital fluid resuscitation. I can confidently say that is wrong. That hurts people. It leads to increased mortality. It leads to increased morbidity. It's bad. It kills people. Don't do that. What took its place most recently was something called, you probably heard this, permissive hypotension. Is that a familiar term? Looking around the room. Anybody raising your hand on that? I remember that you're out there, cyber world. Permissive hypotension might be a new term, I don't know. That's when you were trained in the last con ed you came to. But permissive hypotension was basically the idea, getting towards the idea that I'm talking about tonight, that, hey, you know what? We don't need to return their blood pressure to normal, and we don't want them to leak out pink Kool-Aid from all the holes that they have in them, you know, from the aggressive fluid resuscitation. So we're going to do something called permissive hypotension, and we're going to choose its goal-directed fluid resuscitation using the only fluid we pretty much have in pre-hospital setting, and that's crystalloid fluids. So we're going to allow their blood pressure to be lower than normal. If you read the PHLS book, it says between 80 and 90, or a mean arterial, systolic blood pressure between 80 and 90, or a mean arterial pressure of about 70. Depends on what book you read. I'll say 70-ish. And we're gonna let that be the middle ground. We're not going to do aggressive fluid resuscitation. With permissive hypotension, we're going to give them small fluid boluses to achieve a target blood pressure of 80 to 90. And I said somewhere in the beginning of this that blood pressure ain't killing these people. Is blood pressure in the lethal triad? So what I'm getting ready to tell you right now is, don't give them any crystalloid fluids. Don't give them any lactated ringers. Don't give them anything. And I know exactly the feeling you're trying to struggle to come up with now. It's the word you're looking for is the law of diminishing returns. What does that mean? The law of diminishing return means that their blood pressure can only fall, because you love blood pressure and you want to measure it, can only fall so low and support life. Do you agree with that? Blood pressure can only fall so low to support life. There's a point where this idea of restricted crystalloid fluids, in other words, they don't get any crystalloid IV solution until, no fluid resuscitation, until they get damage control surgery done. And then, you know what they're going to be resuscitated with? Probably. They're going to be 1 to 1 to 1. 1 unit of fresh frozen plasma, 1 unit of packed red blood cells, and 1 unit of platelets. Got to have all of them. Sorry, add them all. But blood products. That makes sense. Lost my train of thought, but bear with me. Don't give them any crystalloid fluids. It's bad. It causes acidosis, and it causes you to bleed more. We're going to talk about that when we get to coagulopathies. How many people can bleed that? Oh, I was talking about, sorry, I lost my place. I was talking about the law of diminishing returns. At some point, their blood pressure is going to drop to a point where they are going to arrest. The trauma-arrested patient, for one thing, has terrible prospective outcomes. Horrible. Less than single-digit survivability. But when they get into that category, this idea doesn't apply to them. This applies to somebody in hemorrhagic shock. Trauma-arrested patients is not hemorrhagic shock. That's a different category of patient, just like the TBI patient is a different category of patient. Can a patient sit up and talk to you and have a good conversation when their blood pressure is 40? Probably not, but can they survive it if we aggressively control hemorrhage, control hypothermia, combat acidosis, fix coagulopathy, and take them to DCS? They might. They might survive. Sometimes people are injured so bad that they don't survive. Sometimes we treat them so badly that they don't survive. So there's the rub. You see where I'm coming from? You just have to choose. Do you believe this science? Do you believe this evidence? You'll have to go on your own and do some more research. That more people are going to survive with this strategy than were with our other strategy. And that's where the rubber meets the road. I think I have more evidence to convince you. Also, when it comes to acidosis, if they have a compounding problem like respiratory acidosis from a tension pneumothorax, or they're breathing too fast, or chest wall instability, sucking chest wound, or whatever, we got to get on that and fix that problem, because it's just going to make the metabolic acidosis that comes from shock worse. All right, we can clear. Okay, I'm not going to read this slide to you. I told you, if you don't believe that lethal triad is what leads to all-cause mortality from trauma, increased rates of all-cause mortality due to trauma, then you're not going to, everything else you're going to have to flush what I'm saying. The lethal triad is what kills people who have trauma and things that crystalloid IV solutions do to people. You gotta really think carefully about what you're doing. All right, next slide. Question.
There was a question, is it true for burn trauma as well, restricted use of crystalloids?
That's an excellent question, and here is the best response I'll give you in 2 minutes or less. Just like the TBI patient is a different category of care, not all trauma is the same. I said that at the beginning. We've got to look more closely at it. Just like the trauma arrest patient who's arrested is a different category of care. The burn patient, where the isolated trauma is burn injury, probably does benefit from large IV boluses, the Parkland burn formula for lactated ringers. However, in most cases, unless it's an airway burn or something like that, that burn is going to kill him in, let's say 72 hours. Unless he's got acute burns to his airway or something that's another life threat in the ABC category, the burns are going to kill him in 72 hours. If he also has concomitant trauma, right? He was in a bad car accident, busted his chest, liver, bilateral femur fractures, and is dying from hemorrhagic shock due to the trauma right now in front of you, then yes, he falls under this guideline. Because he's going to die from the burns in 72 hours. He's going to die from hemorrhagic shock if he doesn't recreate a state of hemostasis in the next 8, 10, 12 hours. He's going to die from that. So we have to pick our battles. We can rehydrate a patient who's burned to death. We fluid resuscitated the burn patient to death. High five. All right, so next key principle is reducing coagulation. That's an excellent question. It's about categorizing your trauma patients and making the care specific based on science. That's what we're talking about. Reducing coagulopathy. Again, top bullet point for reducing coagulopathy is hemorrhage control. If we can limit the amount of hemorrhage, then we give the body a better chance to mount a resource in the coagulation category to fix it. Remember, coagulopathies happen in the presence of acidosis. The body doesn't have the same ability to produce clots when the body is acidotic. So we got to manage acidosis, so that's the slide before I just talked about. And then we have to deploy restricted use of crystalloids because when we raise the blood pressure on these unstable clots, we wash them away. But they don't have enough resources to recruit fibrin to stabilize a clot in the time that we are dealing with the massive hemorrhage. Then by just adding more pressure in the pipes, we're going to wash away the clots that we are trying to build, make, you know. And then the other thing is that increased intravascular pressure, you know, if it gets higher than the outside pressure, then you're just going to force the clots out through the hole, at the very hole that they're trying to clot. So there's restricted use of crystalloids all over again. And then finally, possibly a new bullet in our gun, administration of tranexamic acid, TXA. Anybody heard of TXA before? Okay. This is one thing I want to kind of get a little bit further, and I know I have 20, is that clock right? I have 22 minutes. The good news is this will only take me 25 minutes to explain, so we were right on track. The TXA is a new medication that specifically might give us more capability to reduce coagulopathy. So let's talk about TXA as a possible treatment to one of the sides of the lethal triad. Okay? So there it is. What is it not? It is not an IV fluid in a bag that you hang and somehow suspends oxygen in its molecular structure, and that oxygen is then delivered to your hypoxic cells. That's what I thought when I first heard about TXA, you know. We can't carry blood on the trucks. It's not feasible, really. We've tried, multiple attempts have been made throughout the years in the pre-hospital setting to have blood available to trauma patients, but it's unpredictable. You don't know what blood type, and storing it for long periods of time, and it just puts the demand on the blood system in the United States. It's just unreasonable. So I thought, TXA is just like synthetic blood, fake blood. No, it is not. Its specific purpose is to combat that one side of the lethal triad, coagulopathy. You might see it packaged under, God forgive me, cyclopropam. That's why I call it TXA. So what is it? It reduces blood loss in trauma patients with severe hemorrhage. Well, how does it reduce blood loss? If you had to guess before we click any slides, what do you think it does? It's a hemostatic agent. I like that. If I say hemostatic agent out loud, the military people, they think about chitin-based blood clotting like gauze and stuff. But what are the other names for those gauzes? Quick clot.
Trying to say.
There's all kinds of commercially available, but not that kind of hemostatic.
No.
But by virtue of it stabilizing hemorrhage, it is a hemostatic agent. I like that. Let's click it. What's the mechanism of action for tranexamic acid? There's no possible way I'm going to be able to read that, so I'm going to put it here. I'm just going to read this to you. This is special thanks to Sarah Carver, paramedic student at Matsu, who this is her homework that I'm reading to you right now. Tranexamic acid is a, she's a very smart girl, I trust her. Tranexamic acid is a synthetic derivative of the amino acid lysine. It's required in the clotting cascade that inhibits fibrinolysis, which is the breakdown of fibrin, which, remember that sticky stuff, the web that makes clots stable? So it prevents the breakdown of fibrin by blocking lysine binding sites on plasminogen, a part of the clotting cascade. It's a medication that inhibits the breakdown of fibrin and thus helps prevent clots from dissolving. That sounds like a good thing to a person who's desperately trying to make clots and keep them stable. By stabilizing the clot, it allows the body a chance to plug the holes and stop the rate of bleeding. TXA is most helpful with internal bleeding that cannot be otherwise controlled, and best when given shortly after the injury, ideally in less than 1 hour. Who is standing there by this massive hemorrhage patient in less than 1 hour? Dr. Jones, Dr. Smart, Dr. Armstrong. That's the code at the hospital when the patient's getting belligerent. They say, Dr. Armstrong, paging Dr. Armstrong. None of those guys are there within 1 hour, rarely. Who is there? But 1 hour. Yeah, we are. All right. Let's go for one more. This is the minutia of TXA for those of you who are really interested. The pharmacokinetics, its onset is 5 to 15 minutes. It starts doing its job between 5 and 15 minutes. That's a good thing. It works quick. Its peak effect is 3 hours. So after 3 hours, you have diminishing effect of the medicine. It lasts for about 3 hours. That kind of makes sense. And its half-life is about a half an hour to 2 hours. So when you give it at the therapeutic dose, in about a half an hour or or so, you have about half the concentration doing its job inside the body, and so on and so forth. So what are the indications of giving somebody TXA in a pre-hospital setting? Evidence of marked blood loss. That makes sense. Sustained tachycardia. Why would the person be in sustained tachycardia? And specifically, they must be in it for this reason. Compensation of blood loss, the compensatory mechanism of tachycardia. They have an initial systolic blood pressure of less than 90, right? So we are concerned about perfusion pressure. We're just trying to give it back in this artificial way with crystalloid IV fluids. We like to maintain it. We can't give it back with crystalloid IV fluids. That doesn't work. Sustained hypotension. They stay in a low blood pressure state for a long time. By the way, you have to have some reason to believe they're bleeding if they have a low blood pressure, which could be a mechanism of injury associated with hemorrhagic shock, or it could be OB patients or GI patients maybe bleeding. And then major trauma with suspicion for pelvic and or abdominal injury, and that would be called occult bleeding. They got a low blood pressure, they're tachycardic, they had a mechanism of injury that could have broken their pelvis, and you can't tell if they're bleeding or not, but it could be bleeding to death inside of their pelvis. And then major arterial bleeding that you had to put a tourniquet on for. I think we could all recognize major arterial bleeding that you had to put a tourniquet on for. That indication would be obvious to us. What are the contraindications? We can move one forward. They're in shock for any other reason than hemorrhage. Neurogenic shock. Do they need blood clots for neurogenic shock? No. They need their pipes to be squeezed. Other non-traumatic shock. Active intravascular clotting. In other words, they have a coagulopathy that goes in the other direction. Too much clotting for whatever reason. Subarachnoid hemorrhage. So not sure how this plays out with head injury. So that may not be something that's an indication. Hypersensitivity to tranexamic acid. No, they have a large reaction to TXA. And then upper renal tract bleeding because a clot there in the wrong place might cause complete renal failure. Just because they got a little blood in their pee does not mean they need to get TXA. What are the precautions? Avoid use of TXA when they have other coagulation factors already going. Do we have other coagulation factors already going in some of our patients? It's possible that some of our chemotherapy patients are getting some stuff to promote white blood cell production, red blood cell production, and that kind of stuff. And so we got to be careful with that kind of stuff. And then, as I said before, TXA has not been shown to cause significant increase in no, I didn't say this before. Sorry, I misread it. It's not been shown to cause significant increase in DVT or PE, which would be, I would be concerned about having a clot in the wrong place at the wrong time, or an MI or a stroke. So there's just not the evidence. We shouldn't say that it means it won't. We just don't have enough evidence from the studies that were done. And then you can read the side effects for yourself. One of them being muscle pain. Not really any known incompatibilities or interactions between TXA and other medications, other than we talked about not giving it with other hemostatic agents. And then this is the dosage that's kind of widespread. We would give it, if we were going to give it, we'd probably do something like this. After we've recognized the indications, we would give them a 1 gram IV bolus of TXA. They would need probably under kind of the current protocols to get another gram in 8 hours, but that's not going to be us probably. It could be though. If you were waiting for LifeMed or another fixed-wing Guardian or somebody out in Bethel, and you had a severely injured patient, hopefully you were on telemedicine, hopefully you had medical control going with you, and you decided to administer TXA, it's possible in Alaska that you do give that second dose after 8 hours, right? It's also possible that you might have blood drawn up and be able to hang blood too. So there's some other things to consider as far as that goes. So that's kind of the drug picture for TXA. Any questions about kind of what it is? Did that, for those of you that heard of it, didn't know anything about it, does that kind of clarify some of the details of TXA, what it is, demystify it a little bit?
Just in regards to the medication, if your patient had like maybe a hypersensitivity to the drug, could you pre-treat with Benadryl or some steroid? And if the patient really needed this medication,
What's the payoff? Yeah.
I mean, is it worth to take that risk?
I don't know that it's been out there long enough for patients to know they have a hypersensitivity to it. I think you're going to give it and see, oh, look, they have a hypersensitivity to it. I don't think that it's so new. I don't think patients will say on their allergies list, I'm allergic to TXA. If they did, that is an unlucky person. It's like the second time I massively.
There was a question about the costs of TXA.
It's not expensive. We're going to talk, if you flip forward to one screen.
It's around $100.
Yeah, it's been around for a minute. If you flip forward.
It's around $100 a dose.
What's that?
$150 a dose.
About $100 for a vial that's 10 milliliters and has a gram in it. But what Aaron's saying in the front, if you can't hear him now, is TXA is not a new drug. This is a new application of an old drug. So they've been using it in cesarean section OB patients for a while. Cardiac surgery. There's been other surgical in-hospital uses for TXA. So that's an excellent question. Whoever answered, who is the person that answered that question? Is their name on there?
Yes. Ronnie.
Ronnie. Thank you for asking that question, Ronnie. You are among great researchers because there was a research study called CRASH-2. It's a big study performed in the UK. It had 20,211 patients, and the purpose of the study was to understand the effectiveness of this of TXA as a therapy in pre-hospital for trauma, and to look at the cost of it. Was there a cost benefit to giving TXA to injured people that improved mortality? That's what I'm saying. So that was part of their study. And then they also wanted to understand if it made clots, it would make people die and get worse. So the CRASH-2 study was a big study. 20,000 people in a randomized controlled trial has all the bells of quality science. It's a big number of people, kind of gets rid of some outliers. It's randomized, so the doctors and the patients don't know who's getting what treatment therapy, and it's controlled. They have controls of patients that were getting the therapy and patients that weren't getting the therapy. That's if you're not a researcher, I'm saying things that might be kind of foreign, but all of those things says this is a good piece of evidence. That's the kind of stuff we look for when we want to try to change practice. If you just want to get smarter, you can read all kinds of research. If you want to change the practice of a system, you got to have really good science, good evidence. And this is a singular piece of good evidence. So what's the conclusion of the CRASH 2 study? That early administration of TXA safely reduces the risk of death and bleeding, death from bleeding in trauma patients, and is highly cost effective. Treatment beyond, caveat, a treatment beyond 3 hours of injury is unlikely to be effective. So we need to be on the front of the coagulopathy problem with TXA. If we get behind it, where the coagulopathy is already pretty bad, we're not forming clots, we're running out of platelets, we're running out of clotting factors, we're running out of recruitment resources, then there's no clot to stabilize. See what I'm saying? By reducing the breakdown of fibrinolysis. So in the first hour is, in this study anyway, was the best outcome. The other study that a lot of people point to is a study called MATTERS, and it is the military version of essentially kind of a CRASH, but it's not as big and it's retrospective. It's an observational study. So again, if you're not a researcher, you wouldn't know that that's not the best kind of science, but it is supportive evidence for what kind of stuff we kind of already know. But so MATTERS was a retrospective observational study that compared TXA administration with no TXA patients receiving at least 1 unit of packed red cells. So that's one thing we can't do. We can't give the patient packed red blood cells. We just don't have the ability to do that. They do in the military, and they did. The size of the study was about 900 people, and of those, about 300 people got TXA. In the end, the military decided that the use of TXA with blood component-based resuscitation following combat injury results in improved measures of coagulopathy and survival. I put a note in my notes that said it's supportive evidence for a couple of things. One, TXA is probably safe and improves mortality from trauma. But two, they don't give crystalloid fluids in the military. Dun, dun, dun. All right. I think I'm getting to the end. So before we flip, does anybody have any questions? Let's just open it up, and in your best North Carolina accent, what questions are out there? Or what concerns are out there? What thoughts are out there? You got something? It's okay to say it.
The CRASH 2 and the MATTERS study, they went on at the same time, basically, in the early thousands, I think, whatever it was. Have they been repeated with those results?
Right. So we're talking about good evidence versus enough evidence versus repeatable science. So there's stuff going on right now on this topic of the use of TXA. I don't think anybody is doing anything but changing their practice on the restrictive use of crystalloids as an alternate to this idea. But there's studies going on. There's a study going on right now. I think it's called CRASH 3. And CRASH 3 involves TBIs and some other factors related to TXA. So we'll be interested to see what more information we get about TXA.
So we have a question, when can we expect to see TXA in Alaska?
TXA is in Alaska. Lifeman carries TXA on the helicopters, and patients in your neighborhood have gotten it. If they were trauma patients and they met some of those indications that I read earlier, I basically kind of read to you the protocol written. Are you a Lifeman person? Guardian. Well, critical care, transport flight, that kind of stuff. It exists. Guardian has it too.
No, we don't carry it.
Well, Lifeman has it. It's already being used in our neighborhood and in our in Alaskan patients already.
So I'm going to have, Andrea, can you unmute yourself? Do you want to ask your question? Oh, can you hear us, Andrea?
If she doesn't ask it in a southern accent, cut her off immediately.
All right, I'll just ask Andrea's question. She asked, how does an EMT know if there is an active intravascular clot formation?
Oh, what a good question, right? How do you know if they have a traumatic brain injury? How do you know if they have internal bleeding? And then beyond that, how do you know that they're actually getting, they're under a hemostatic state, they're controlling their bleeding? You don't know. You don't have a magic wand to know. We assume that they're not until it's proven that they are. I mean, you know what I'm saying? If their skin is cool, pale, and clammy, they have no radial pulse, they've got signs consistent with major internal bleeding or uncontrolled external bleeding, then they're fighting a fight to form clots with limited resources. They run out, resources run out, platelets run out, fibrin runs out, clotting factor run out. When I say run out, I mean they're in limited supply. They also run out, like run out of your body. So you don't know. But an EMT, the assessment stuff that I talked about, I'm glad she mentioned that EMT thing, because the assessment stuff that I talked about is not paramedic stuff. I only talked about one thing that would possibly be paramedic skill, TXA. The rest of it's warming up your ambulance, putting on a blanket, managing external bleeding, decreasing scene times. If anybody in this room says diesel bolus, I'm going to kick you out.
All right, let's see if we try again. Ronnie, do you want to go ahead and ask your question? Robin's here. Oh,
They want to talk.
yeah, Ronnie had a question. What are they using? Specific blood component based?
Okay, so what's going on in the military right now is a couple of different things, but what's kind of at the heart of I'm going to say fluid resuscitation, but resuscitation in the military is that one-to-one-to-one thing. 1 part whole blood, 1 part packed red blood cells, and 1 part fresh frozen plasma is at the heart of fluid resuscitation. Tell me if I'm wrong about this. This is at the heart of fluid resuscitation in the military. They also have this battlefield transfusion protocol where one soldier gives another soldier blood in the field, but it's not the best way to do it. There's some problems with it, and it's been implemented in very limited resources. But what they don't do, what they don't teach combat lifesavers anymore, is spending that time under fire getting an IV, spending time under fire trying to hang a bag, and you see this sort of quintessential military picture of the soldier with a bag in his mouth. And he's getting an IV and his gun's on the ground, or soldiers around him starting fire. They don't do that anymore. They don't even teach it in combat like CLS class anymore. It's out because it didn't help trauma outcomes. What helps is to win the battle and drag the guy to damage control surgery and not get shot.
All right, another question was, can we use it on patients with suspected internal hemorrhage?
Yes, yes, and yes, comma, ... maybe. Because I got to make sure you understand, we're talking about categorization of our trauma patients. I've specifically chosen to talk about the person dying from hemorrhage who's moving along a continuum, a spiral downward towards hemorrhagic shock. So they end up in another category as well, like TBI. They had a car accident with multi-system trauma, and they have a traumatic brain injury, and they have an internal hemorrhage in their belly. Then they're probably not in this category, and then we don't have the evidence to say whether they fit that, they would fit the TXA protocol or the restricted fluid protocol, because we do have to support blood pressure to perfuse the brain. So some of that stuff hasn't changed, but it's about categorization. Every trauma patient's not the same. We got to get smarter about it. That's a good question, a very good question. But if the idea was they got blunt trauma to the abdomen, isolated blunt trauma to the abdomen, and they have Cullen's sign or Gray-Turner sign. They're ecchymosis around the belly button or ecchymosis over the flank. Positive finding for retroperitoneal bleeding or peritoneal bleeding, and that's it. That's isolated it. That's a perfect indication for TXA. According to what we know now, the evidence that we have now.
All right, let's see. William was going to try and ask a question. We unmuted him, but he is muted, so. Go ahead, William.
Can you hear me now?
Hey, yes, I can hear you. Hi, Will.
Great. So a question around TXA, and would there be any contradiction with erectile dysfunction medications?
So those are different pharmacodynamics, right? So I think I get why you're saying this. William, are you an EMT, an EMT2, an EMT3, or a paramedic?
Used to be a 3, back down to a 2, or a 1, I'm sorry.
All right, very good. So tell me if I'm right or wrong. The heart of your question is about the known conflict between sildenafil and those other drugs and given nitroglycerin for a dangerous drop in blood pressure. Is that the heart of it?
Correct.
Is that at the
Yeah, correct.
conflict? Is that at the heart of your question? Yeah. Here's what you're talking about. Not raising a person's blood pressure with TXA, certainly not lowering it with TXA, but creating a hemostatic state, an intact vasculature, so that a blood pressure can be maintained. So whether or not they were taking sildenafil is probably not likely to be a precaution or a problem. Does that make sense?
Okay, yes, thank you.
That's a good question.
All right, we've got one more from Ronnie. Oh, we unmuted her. Go ahead, Ronnie, can you ask a question? Oh,
He's desperately pushing buttons on his phone
Right.
or on his computer right now. I've been there, I understand.
all right, Ronnie's question was, which again come through, is to say, what did you say about the military and the use of crystalloids?
Okay, so I was referring to the Matter study. In my typical Southern Cavalier way, I read it between the lines of the Matter study. And so the Matter study is talking about how that they demonstrated in those few patients, those 900 patients, that the patients who got TXA died less often than the patients who didn't get TXA. The caveat for that study, though, is that their TXA therapy was always combined with a blood product, because the blood product is the central fluid resuscitation of their trauma resuscitation protocol. So then I flippantly said, there's two takeaways for me in this thing. One, TXA is potentially good for wounded people, and two, the military doesn't use crystalloid IV solutions for a reason. You know what I'm saying? It underlines and underscores this restrictive fluid resuscitation thing. Does that answer the question? I'm never sure if I'm actually answering the question or if I'm just rambling on with stuff.
She hasn't replied back. So.
Okay. I don't like this guy. I don't know. All right. So let me close with this. If another question pops up, we'll take it. But let me close with this last slide there, John. I think I've done a fairly good job of explaining why this is important, because hemorrhage is a major cause of death after injury. There's other categories that kill people too, trauma and burn, head injuries and burns and stuff like that. But hemorrhage is a big category, and it deserves a look. It deserves some consideration. You got to believe that the lethal triad of trauma is deadly. It kills people. And not that number. I always say SAM over DOLLY to remember systolic over diastolic, because I learned that in EMT school, and I learned that because they were teaching me blood pressure, because it's so important. Listen to what I'm telling you. It's a vital sign. By the very name of it, it has a high priority in your care and treatment. I'm just saying here, that number is not necessarily what kills people. You got to believe it's the lethal triad, so that you focus your energy and resources on that. But it's the underlying pathophysiology that increases mortality post-injury. And then third, pre-hospital assessment and management that's focused on attacking hemorrhage control aggressively, managing acidosis, managing to not make acidosis worse, and to improve it where we can. Think about respiratory acidosis. Minimizing hypothermia, which has to do with exposure, and real high-tech stuff like blankets and ambulances and heaters in ambulances, stuff like that. And then combating coagulopathy by fixing those other things, and maybe with TXA. Probably with TXA. For sure, probably, we should give it a shot. We gave amiodarone a shot. It has exactly zero evidence supporting it. Well, you should give TXA a shot. It's got evidence. And anyway, those are the keys to improving outcomes. So that's my kind of wrap-up conclusion. Thank you for having me. I know it's hard. I'm like sandpaper sometimes on people. My accent, my attitude, my off-comment and off-color remarks. If I've offended anybody, I apologize. But know that it comes from this place. We should have fun, but take seriously the work that we do, because it has purpose. And we should be willing to have these kinds of conversations, and we should be willing to argue about things that we don't agree with. We should be willing to explore things that we don't understand, and we should be willing to look at new information to apply it, because it's all about one thing: pancakes. You thought to say outcomes. It's all about making pancakes. And so I want you to have a good time learning about stuff. I want it to be interesting. I want to rub you the wrong way, because God knows you start thinking and blood starts flowing real good, that kind of stuff. So hopefully you're going to take something away from it tonight. It might be too early to have a sea change in your practice and your protocol and go attack your medical director tonight on what you've heard, but it's not too early to start talking about what you learned with him and ask him what he already knows. Probably knows a lot. Have those conversations with him about this stuff, and he may already be thinking about moving in that direction or making some changes. So, as always, follow your local protocols. This message has been brought to you by the Southern Region EMS Council. How'd I do? Is that okay? All right.
So, and everybody thank you, Dane, that was excellent. Everybody in webinar land, remember, if you were in a group tonight where you guys were listening in, please send me your group roster to registration@sremsc.org. If you were by yourself, I will see that on the webinar, and you don't have to send me a roster for yourself. But if you were in a group, please send me that roster. CME certificates will be posted on our website by next week, around about Wednesday. And please sign up for other webinars. We are taking a break June and July, because apparently Alaskans like to enjoy their summer, ourselves included. So we'll start back up in August. I think Dr. Jaron Coombs from Matsu will be speaking. I don't know his topic yet. So, but we do have the other topics for the rest of the year. Go sign up for that. So you have
I just also want to say, if there are any research geeks, and some of the references are in my notes, and they might not be able to see them, but if they want it, I can send you all that research stuff that I quoted, and if they want to click through and see it, it's all on the internet. So.
Perfect. Any other questions for Dane? Hope you're getting a bunch of thank yous.
Bye. Thank you for
Thank you
joining
very
and
much.
listening.